Hi there, thanks for joining. So today we're going to talk about metabolic and endocrine emergencies. Sorry, I was just trying to get my laptop situated. So I've got some case examples that we'll go through. So there's quite a few, but if you have any questions, feel free to chime in or put it in the chat and I will check the chat at the end. Let me see if I can figure out how to move the slides on this. Okay. So the first case that we'll talk about is a 10-year-old female spayed Bichon who comes in for lethargy, inappetence, vomiting, and diarrhea. She has been PUPD for the past month, the owners report, and she has a pot-bellied appearance. So her blood work showed a blood glucose of 687. Her ALP was 1321. Her white blood cell count was 22,000, mostly neutrophils, and her urinalysis showed a USG of 1025 with 3+ glucose and 2+ ketones. And her blood gas, her pH was 7.12 with her bicarb being 12. So this is a pretty classic example of DKA. So diabetic ketoacidosis, probably one of our most common endocrine emergencies that we see. Certainly quite costly and very involved. So most of these cases are just going to be a brief overview of stabilization. Obviously we could probably talk about each of these diseases for an hour at least, but I kind of wanted to do an overview just of kind of the emergency aspect. But diabetes is obviously a complication, or ketoacidosis is obviously a complication of diabetes. So you get hyperglycemia, metabolic acidosis, and ketonemia. So basically you've got a relative lack of insulin and an increase in your counter-regulatory hormones. So those would be like your glucagon, your epinephrine, your growth hormone, and your cortisol. So those are going to be increased due to some sort of underlying condition or unregulated diabetes. So basically you have glucose that can't enter the cells to form ATP, and then you have decreased pyruvate production, and then you have decreased utilization of acetyl coenzyme A, and then you get ketone body formation. So the ketone bodies that we have are acetoacetate, beta hydroxybutyrate, and acetone. So here is just a little chart that we won't go through entirely, but basically we won't review the full pathophysiology, but basically the main thing is going to be the ketone formation. So our risk factors for ketoacidosis in dogs, it's going to be acute pancreatitis, UTIs, Cushing's disease, in cats, hepatic lipidosis, chronic renal failure, acute pancreatitis, infections, and neoplasia are common risk factors. Most of these cases are going to be newly diagnosed diabetics, middle-aged to female dogs, and then older male cats are also predisposed. So clinical signs that we can see are PUPD, pretty classically, lethargy, inappetence, vomiting and weight loss, weakness, collapse, dull mentation. Some people can smell the fruity smelling breath, others can't, but that is pretty classic. And then whatever other underlying disease they may have. So signs of pancreatitis or Cushing's may also be present. On your blood work, again, it's going to be a pretty marked hyperglycemia. You're going to have ketones in either your urine or your serum. You can have a metabolic acidosis due to the ketone formation. Typically, you'll have evidence of dehydration, so some elevated protein levels, increased liver enzymes. The hyponatremia you can see pretty commonly with high blood sugars, and that's mostly due to intracellular fluid shifts. So it's actually a pseudo hyponatremia, which we'll talk a little bit more later, but there's a correction factor for that. Hypercholesterolemia is common. They can have a non-regenerative anemia and then other electrolyte abnormalities, which we'll talk about in a moment. So like I mentioned, for the corrected sodium, the formula is there, and there are quite a few formulas throughout this presentation. As criticalists, we love them, but obviously I don't have these all memorized, so I just kind of have them all on a sheet that I look up if I need it. But if you're worried about a sodium level in a diabetic animal, definitely do the corrected, because once you do this formula, it might actually not be low. So again, it's going to be falsely low because of the high blood sugar and the fluid shifts. So the water is going to go from the intracellular fluid compartment to the extracellular fluid compartment. So it's kind of diluting the sodium. So that formula is listed there. So as far as treatment goes, fluids, we want to treat hypovolemic shock if present. So your typical fluid boluses, if they come in and their blood pressure is low or their shock index is elevated, we typically will calculate the fluid deficit and replace that over 10 to 12 hours. So if they're 5% dehydrated, we'll calculate for that and correct that over 10 or 12 hours or so, and then adjust the fluid rate once they're euhydrated. You can really use any fluid choice. So we typically will go with LRS. And then the BG, it's important to note, can decrease with fluids alone. So I'll typically, we'll get a blood sugar on admit, and then once we start fluids for a few hours, I'll check it again before we start the insulin CRI, if there is a bit of delay there, which we'll talk about. And then I almost always add potassium to my fluids just automatically, even if the potassium is normal, because it will decrease once you start them on insulin. The only scenario where I might not is if it's a little high to begin with, but I would definitely rechecking electrolytes within 6 or 8 hours of starting the insulin CRI, or the insulin if you're going to do like an IM sub-Q protocol for cats, because it will likely decrease and you'll probably need to supplement in a day or two, if not from the very beginning. So in talking about the insulin therapy, there are several different protocols that you can use depending on the paper, depending on the book that you pick up, where you've been trained, if you're a criticalist versus an internist. So I think I have 2 examples here. This is the one that I was taught during my residency, and I don't really push for this anymore. I kind of just go by what the internists like here at MBS. But we used to do a unit per kg of regular insulin. So always regular insulin for your CRIs in cats, and then 2 units per kg in dogs. And then we would adjust the blood sugar based on this chart here. So the nice thing about this is that you're increasing by 1 or 2 mils an hour as the blood sugar is getting higher each check. Whereas in some of the other ones, you need to pay more attention. So if you are working a busy ER shift, or you don't have time to look at the BG each check, it may be easier to do something like this. So the technicians will automatically turn it up, versus definitely seen cases where the blood sugars are in the 500s all night because they just left it at 10 mils an hour instead of turning it up. So that's one benefit to this one. The other thing you'll notice too is what we do with the fluids. So again, debatable, but you need the insulin to clear the ketones. So a lot of people will add dextrose to the fluids. So just the regular IV fluids, not the insulin CRI. So these patients will have 2 fluids going. So that's why it's nice to have either 2 catheters, or ideally a central line or a sampling line. So their insulin CRI, we don't really mess with that once we've made it, unless it's not working. But the IV fluids we can change. That's where we'll put our electrolyte supplementations. But sometimes we will add dextrose to the fluids. And the reason for that is if there still has a lot of ketones present and we want to get the ketones cleared. So some people don't do that. You certainly can. It does make things a little more complicated. But that is one CRI method. Another one is the one we use more commonly at MBS, and this was Dr. Wong's approach, and I think it was in a very popular paper, but she always does 2.2 units of regular insulin per kilogram in dogs and cats. So the adjustment for hers is here. So it's more of a rate. So 10 mils an hour, 7, 5, and 3, whereas the other one you were doing increments. plus or minus the dextrose. A lot of people don't, and I've kind of stopped adding it as well. And I feel like I haven't gotten much of a difference or any negative effects. And the other thing too is for cats. Which one do you want to use to listen to this? I don't know what's going on, sorry. Siri is making noise. So basically, when to start the insulin, the earlier is typically better. There was a study that looked at early versus late administration, but then how early, it's still kind of debatable. So in the study that looked at this, they looked at dogs that got insulin within 6 hours versus more than 6 hours. So the average time was about 4 hours. So what I would be interested in knowing is whether you start it right with fluids or after it. But I will typically try and wait at least 2 or 3 hours on regular fluids. And again, the reason for that is because the blood sugar can decrease with insulin, with the fluids alone. And then the other thing, as I was saying earlier, in cats, this could be a lot of volume for them. With this particular formula, it's not, but with the this last protocol I showed you, it can get quite high. So we would often kind of make the insulin double concentrated and then just have all the rates. So that's something that you can do if you have a cat or a small dog and you're worried about volume overloading them. You can always double concentrate. So you could add like 4.4 units and then you would just run it at 5, 4.5, 2.5, things like that. So that's something you can do as well. And then if you're not wanting to do a CRI, we often do that because it's honestly easier than using the regular insulin or the sub-Q glargine. And with our cost of hospitalization and things, it's pretty much equivalent. So if this option were a lot cheaper, or maybe in your GPs, this might be a better option when you don't have the regular insulin, because some of these just use glargine. But there's been several studies, so I'm not necessarily going to go through all of these. I think probably for you guys that might not have regular insulin in your hospital or don't really know, like, is it worth stocking it? You can definitely try this sub-Q IM glargine protocol. So that is one that they did with cats. So they gave every cat 2 units of glargine sub-Q as soon as they walked in the door. And then they gave it another unit of glargine IM 2 hours after that first dose, and then every 4 hours as needed if the BG was greater than 250. And so that was the IM, but they were still giving the sub-Q at 0.25. That should say units. It does say units per kg every 12 hours. And they actually found with that paper that those cats got out of the hospital quicker than cats that were on insulin CRIs. So that I have done kind of a combination of that before. I think, during my residency, I did the glargine plus the regular insulin boluses as needed for some cats, and I found that it worked just as well. I don't have much experience in dogs, but you could probably search to find a paper, or that may be a good paper idea for some future residents. The other thing to kind of consider, well, there's many things, but one of the major things is managing your electrolyte abnormalities. So the potassium, as I mentioned, we always want to supplement even if it's looking normal initially, because these patients will be total body potassium depleted. And then once you start the insulin, that's going to shift the potassium into your cells. So it's going to drop even further. So the similar thing happens with phosphorus. So they're going to be total body phosphorus depleted. And then you get the cellular shifts as well. So we will typically start with just maybe 30 or 40 milliequivalents of KCl in the fluids. We can go up to 80 milliequivalents per liter of KCl. And then if our phosphorus starts to drop, then we'll supplement K-phos instead of KCl, sometimes together. It can be very confusing, but we'll talk more about KCl supplementation in a later case. The K-phos, or the potassium phosphate, just has a little more potassium per mil than the KCl. So it's 4.4 milliequivalents, and then the phosphorus is 3 millimoles per mil. So there's just a lot of calculations that go into this. Magnesium CRIs are sometimes necessary if you can't get the potassium up. Then it's often, that could be because the magnesium is low. I will say I haven't done this in years, so I don't find it often to be necessary, but certainly something, if you have the ability to check it and supplement it, it may be worthwhile. So other treatments, you want to treat secondary diseases. So your gastroprotectants for pancreatitis, pain medications, anti-nausea medications, antibiotics if you've got a urinary tract infection or other source of infection. And then nutritional support. So often these patients aren't eating, so we'll do nasogastric tubes, things like that are all things to keep in mind. As far as monitoring goes, we typically will do our blood glucose every 3 hours minimal. So for that reason, we like to have a sampling line or a central catheter so we don't have to poke the animal every 3 hours. I've pushed it out to every 4 hours, especially in like the IM or sub-Q cases, but really things can change quickly. So every 3 hours would be ideal. And as far as the Freestyle Libres, if any of you guys are using those, there was a paper that looked at using Freestyle Libres in diabetic ketoacidosis dogs. It didn't quite meet the requirements to be considered fully accurate, but the authors concluded that it was clinically gave an accurate depiction. So in general, the Freestyle Libre is going to read about 40 to 120 points lower than normal. So what we'll often do in our orders is write, like if the blood sugar is less than 60 on the Freestyle, then check the actual blood sample. And typically, you would want to check like the first few and make sure that they're matching the readings. But the paper was mostly looking at like, due to all the other metabolic derangements happening with DKA, does the Freestyle Libre work? And the answer was yes. And again, that's only been studied in dogs, but I'm sure our internists have probably used it for some cat DKAs as well. So the prognosis, I really haven't found a lot of papers, newer papers that have kind of disputed this, except for one paper that said that newer studies showed higher survival rates. But I would say, just given that these animals are older and sick, that maybe 70% survival, that may be a little on the lower end. It may be more like 80 to 90, especially if the owners are committed and have the funds to treat. So these are typically very expensive cases, but usually they're in the hospital. The average was 5 days in cats and 6 days in dogs. Obviously that adds up, but there was another study looking at how many pets have recurrent episodes of DKA, and that was about 7% of dogs and 40% of cats. Dogs with Cushing's disease were less likely to be discharged. I think probably comorbidities, plus if you add Cushing's onto your DKA and your central line, you're just asking for a blood clot to form. So I think that probably contributes. And in cats, it's been found that a poor outcome is associated with their initial creatinine, BUN, magnesium, and bilirubin levels, which again makes sense because these are going to be sicker cats. So moving on to the next case. So this case is a 7-year-old female Spade domestic short hair who has a 2-day history of an appetence, vomiting, and hiding. This cat presents laterally recumbent, dull, 7% dehydrated. The cat is thin, bradycardic, hypotensive, and hypothermic. The blood work that you get shows a blood sugar of 686 milligrams per deciliter, sodium of 155, BUN of 57, creat 3.2, ALT of 300, and hematocrit of 29. Your analysis shows 3+ glucose, but no ketones. So this cat, once we kind of calculate everything out, is experiencing hyperglycemic hyperosmolar syndrome, or HHS, or sometimes hyperglycemic non-ketotic syndrome, so HNK. But this is another complication of diabetes. It's not as common as ketoacidosis. And the criteria is severe hyperglycemia, so greater than 600, and hyperosmolality, so greater than 350 milliosmoles per kg. These patients have minimal or no ketones. So the reason that they don't form ketones, or what is kind of postulated, is that there are small enough amounts of insulin circulating, and that there is some hepatic glucagon resistance going on as well. So basically both of those things are going to inhibit your fat breakdown, so you're not going to get the ketone formation. And in order for this to happen, there has to be a reduction in your glomerular filtration rate. So to get glucose values this high, in some of the cases, there's two kind of case series or retrospective studies on HHS, one in dogs and one in cats, that I've ever found. And both of those were in JVEC. And in both cases, I mean, some of these values, like if you send the blood work out, their glucose would be like 1100. Like, how is that possible? You have to have a decreased GFR, because typically there's no maximum loss of, like, maximum rate that glucose can be lost to the kidneys. So everything that enters the kidney should be able to be excreted in the urine. So that's why the levels get so high. So these cases will often have concurrent renal disease or congestive heart failure. So to calculate the serum osmolality, again, another formula. I said there would be quite a few here. So you can always look these things up, but the formula is listed there. So typically you need to know the sodium, the BUN, and the BG. A lot of times you can kind of get rid of that middle part about the BUN, because it does kind of pass through the filtration membrane pretty quickly, but for all intensive purposes, that's the formula that we would go with. So the normal is 290 to 310. It's a little bit higher in cats, but that's kind of an average. So if we go back to the case that we had, I kind of just put our values in there. So if you did the math, this cat's osmolality would be 368. So that's quite high. So clinical signs of HHS are similar to signs of DKA, but often these patients will present in much poorer condition. So all of your behavior changes, PUPD, weight loss, those things, but a lot of them will have neurologic signs as well, just because of that very high blood sugar. So in that study I was referring to, dogs that had an abnormal mental state or were comatose, that was associated with a poorer outcome. So you can also see things like twitching, heart murmurs, things like that. So everything is listed there. So the treatment for these guys, I know we were talking about the controversy on when to start the insulin for DKAs. In these cases, you definitely want to start fluids first. So I think we would typically, I've seen only a handful of these, but start fluids for like 4 to 6 hours. And then recheck a BG and start insulin, basically when the blood sugar is no longer responding to just the fluids alone. So you want about a 50 mg per deciliter drop in blood sugar every hour. And then you want to wait until the patient is euhydrated before you start the insulin. And then typically they don't need as high doses of insulin than those DKAs, because again, we're not trying to clear any ketones or anything like that. We just want to get the blood sugar down. So for these, you can use an IM protocol or a CRI. So the IM protocol is listed there, and then the CRI we set up just as you would for the DKA CRI as far as like adjustments. But again, for the lower dose, we're only going to put a unit per kg in the bag. And then different from DKA, I was mentioning that some doctors will add dextrose to the fluids, but in this case, you don't want to do that because you don't have any ketones to clear and you don't want the blood sugar to come back up. So no dextrose in the fluids for these cases. And then you might even need to check your blood sugar like every 2 hours or so for these guys, because you really want to make sure that you're not dropping by more than 50 to 75 mg per deciliter per hour, or you can get more neurologic signs basically. So because basically what would happen if you drop too quickly is you would get rapid changes in your osmolality, which in one of the cases we'll talk about later can cause some issues. So the prognosis for these guys is not as good as for DKAs. In the case series in cats, there was about a 65% mortality rate, and in dogs, a 38% mortality rate. And they found a worse outcome was associated with an abnormal mental state and a low venous pH, which makes sense because those cases are going to be sicker. So our next case is another common one that we see on ER. This is a 3-month-old female intact Yorkie who presents for lethargy, weakness, and a wobbly gait. So her point of care blood sugar is 32 mg per deciliter. So pretty classic hypoglycemia, small toy breed dog, puppy. So this is something, again, we see commonly. So again, we're talking about just kind of euglycemia being maintained by the balance between insulin and our counter-regulatory hormones. So insulin is going to be secreted by the beta cells of the pancreas when the blood sugar is high. And then your counter-regulatory hormones are going to promote gluconeogenesis, glycogenolysis, and they're going to inhibit the peripheral glucose use and inhibit insulin secretion. So your glucagon and your epinephrine are going to increase rapidly in response to hypoglycemia, and your cortisol and your growth hormone are going to be released a little later, but their effects are going to last a little longer. So again, here's just another picture of the chart. So maintaining the balance can be challenging. So there's a lot of effects that hypoglycemia can have on the brain, particularly because the brain relies heavily on glucose for energy. So if you have prolonged periods where the brain is depleted of glucose, that can cause permanent brain injury. So the clinical signs, they can present for altered mentation, dullness, weakness, blindness, and then seizures is one of the more common things that we think of. So causes of hypoglycemia, there are many. If you think about it in kind of 3 categories, you can have excess insulin. So insulin overdose, very common. Insulinoma, so you have a tumor secreting insulin. You can have paraneoplastic insulin secretion, and then toxins or medications. So xylitol is going to be our #1 toxin, very common. We just had one discharged last week that got into some xylitol gum. And then you have your glucose lowering drugs that humans may take. So your sulfonylureas, your glipizide, things like that. Then you can also think of differentials if you're thinking of excess glucose utilization. So sepsis is a big one. Exercise-induced paraneoplastic, polycythemia, leukocytosis, and pregnancy. And then you have your decreased glucose production. So whether they're neonate, like our case example, liver failure, Addison's disease, beta blockers, things like that, liver shunts, all of that could cause hypoglycemia. So diagnosis is typically just a low blood sugar. So that's probably the easiest diagnosis that we have so far. So another thing to note too that we often will run into on ER is if you're using a handheld glucometer and you're not quite believing the blood sugar that you're getting, whether it's high or low, is just to remember that there is, in patients that are hemoconcentrated or anemic, the glucometers don't work as well. So if you have a super anemic like HGE dog, or I'm sorry, a super dehydrated HGE dog. So we have had one recently where the PCV is 72 and the blood sugar is 65. It may not actually be that low. So if you do this correction factor, you might find, oh, the BG is actually normal for the level of polycythemia that the animal has. And similarly, if you're anemic, then those blood sugars can be falsely elevated. So there's a paper that came up with this formula, again, another formula, but it's listed here. So we use that often. So treating the hypoglycemia, main thing is going to be a dextrose bolus. So we typically will do 0.5 to 1 mils per kg, not mgs, but that's mils per kg of 50% dextrose. We'll dilute it 1-to-1 with saline and give slowly over 3 to 5 minutes. Depending on the case, like for this puppy, If it's still walking around and alert, we would offer food. If it's eating, when we recheck the BG, we may not need dextrose in the fluids, but if the patient is still clinical or if the BG doesn't come up, then we will go ahead and add dextrose to the fluids. Depending on the cause, like for xylitol, we'll just add the dextrose in the fluids right away because those signs can be prolonged and the hypoglycemia may not come along till later. But we typically, depending on the case, we'll start with either 2.5% or go ahead and bump up to 5% if we're really worried. It's important to note that you don't want to exceed 5% dextrose in the fluids through a peripheral catheter. It can cause phlebitis. So if you have to go higher than that, which we definitely have cases where we need to, you can either do 2 peripheral catheters, or my preference would be a central line at that point. Sometimes if you can't get a catheter in, especially these small neonates, you can rub Karo syrup on their gums, rub that 50% dextrose on their gums while you're trying to get a catheter in. There was actually a paper I found that looked at this, and it took about 15 minutes for that to take into effect. It was a prospective, kind of very controlled study. So obviously IV dextrose is best, but those little puppies can sometimes be hard to get a catheter in. So it's definitely worth a shot while you're waiting. And then also don't forget IO catheters as well. Glucagon can be used if you have refractory hypoglycemia. I haven't done this in years, but it is kind of coming up a lot in the literature. So the dose is listed there, but I don't even think we carry that on hand. We'd have to have an owner like go get it if we're having that refractory hypoglycemia from a human pharmacy, I mean. So our next case is going to be a 10-year-old female spayed golden retriever. She is coming in for dulmentation, PUPD, and polyphagia. The owner reports that she was acting a little odd at home when they missed her morning feeding by a few hours, but she's back to her normal self after she had her breakfast, except she's a little dull, I guess. So on exam, she's pretty unremarkable. The owners may think she's a little quiet, but she perks up for you in the back, and on blood work, her BG is 45, but she's just walking around like it ain't no thing. So this dog probably has an insulinoma. That's going to be our top differential if she hasn't gotten into anything and her BG's low and she's not clinical for it. So this is going to be one of those things where, you know, if you see them a few times, it may be more on your radar, but we do see actually quite a few of these. We actually had an incidental one the other day. An animal got hit by a car. It was hypoglycemic. We checked it again, hypoglycemic, did an ultrasound, it had a pancreatic mass. So it's definitely something that we see pretty commonly. But signs are going to be kind of vague. There may be an intermittent history of weakness or collapse. Maybe they've had one seizure or something, but typically when they come in and their BG's low, they're not like actively seizing or having any clinical signs associated with hypoglycemia. So this was where Whipple's triad, I think is a human term, but there's 3 criteria for diagnosing an insulinoma or for suggestion of an insulinoma. And that is your signs are consistent with hypoglycemia and the signs resolve when you correct the hypoglycemia, usually by eating, and the blood sugar is documented to be low. So how do we diagnose it for sure? We usually will pull an insulin glucose ratio. So this is something when they come in and the BG is 45, go ahead and get an extra tube of blood for the insulin glucose ratio, because a lot of times when the BG will come up, either they've eaten, we've given them a dextrose bolus, which sometimes we really don't want to do, but if the BG is not low, then we're unlikely to get a diagnosis. So remember to take that extra blood. And then typically, you know, we'll also recommend an ultrasound, and we may or may not see a mass on the pancreas. If we don't find one on ultrasound, but we're pretty sure, sometimes we will do a CT as well, just to rule that out, but you often may not find it on ultrasound. So the treatment, pretty much 2 options. I think for the most part, medical management is kind of the more common route, and that can be just small frequent feedings, may be enough to kind of feed off the signs of hypoglycemia, if you will. Steroids also are recommended, typically at 0.5 to 1 mg per kg per day. divided BID. And then we typically don't want to give dextrose boluses because that's just going to make the tumor secrete more insulin. So sometimes we have to, but we try and avoid it if possible. Glucagon, again, would be useful for these cases. And there's several other drugs that we're not going to get into that have been tried, but the prednisone and the small frequent feedings are going to be the mainstays. So for surgery, most people will recommend starting medical management first. Some postoperative complications that can occur, like pancreatitis, diabetes, persistent hypoglycemia, things like that. So this was a paper that I found that was looking at basically any dog that came into an emergency room that had an abnormal blood concentration, and just they wanted to see what were the main causes, like what were the most common causes, and then what was the prognosis. So they found that 40% of dogs that presented to an emergency room just for any reason were hyperglycemic, and 9% were hypoglycemic. They found that hyperglycemia was associated with GI disease, trauma, neoplasia, and respiratory disease. And hypoglycemia was associated with sepsis, GI disease, and neoplasia. They found that dogs in shock or dogs that had a high lactate had higher blood sugar levels. And they did find higher mortality rates in dogs that were hyperglycemic, so 33%, or hypoglycemic, so higher mortality rate for those dogs at 44% compared to the dogs that had a normal blood sugar. So for this, there was about 660 dogs, and they measured basically any dog that had a BG checked within 6 hours of admit. Dogs that had a previous diagnosis of diabetes were included in their initial kind of prevalence evaluation, but then after that, they were excluded from the things like mortality, because I think that would definitely skew it. But basically, if you have an abnormal BG on a patient that presents to the emergency room, their mortality rate's higher, whether it's high or low. So our next case is another common ER case that we can get. So a 2-year-old female Spade golden doodle presents for lethargy, inappetence, and vomiting. On exam, she is dull, 5% dehydrated. Her blood work shows a BUN of 41, creatinine of 2, a sodium of 125, a potassium of 6.2, a BG of 67. The dog's CBC is completely normal. Her USG is 1020. She has no signs of a UTI. You do abdominal radiographs. Those are also boring. So this is typical presentation for the great pretender, Addison's disease. So basically, we're talking about deficiency of adrenocortical hormones. So your primary hypoadrenocorticism or Addison's disease is the main one that we think about. So you have adrenal gland dysfunction. You can have atypical Addison's disease, which is just a deficiency of glucocorticoids alone. So your mineralocorticoids are not affected. In those cases, their electrolytes are typically normal. And then you can get into the more rare cases like secondary or tertiary hypoadrenocorticism, which hasn't really been reported, but if you have some sort of dysfunction of your pituitary or your hypothalamus, but essentially we're looking at the problem being at the adrenal glands themselves. And typically it's going to be an immune-mediated destruction of the adrenal glands that we're looking at. You can have iatrogenic Addison's, so basically withdrawing steroids that have been used long-term. So that's why we always want to wean. Or if you've had a patient that's been on mitotane or trilostane therapy and they're ill, you definitely want to check out baseline cortisol because they could now be Addisonian. And you can also get sort of Addison's secondary to things like cancer or anything like trauma, things like that, but it's much more rare. So these are typically going to be young to middle-aged female dogs, some overrepresented breeds. I think poodles are the poster child, Westies on the bottle, Portuguese water dogs, The list is there. It's rarely been reported in cats, but it has been reported. So clinical signs can be pretty vague. Again, it's kind of the great pretender, so it can look like anything. I would say lethargy, weakness, vomiting, all common. Often they'll come in collapsed and shock if they're in crisis. It can be bradycardic, hypothermic, things like that. So on your chemistry panel, hyponatremia and hyperkalemia are going to be kind of your classic findings. Again, if you have atypical, you may not see that, and that one's even harder to kind of pick up on or put on your differential list. But basically, if you have a low sodium to potassium ratio, so less than 28.1, a lot of them are hypoglycemic when they come in as well, so about 38% in one study. They're often azotemic. They may have elevated phosphorus, low albumin, hypercalcemia. They can have a metabolic acidosis, so they can have a lot of electrolyte derangements as well. So just to throw this out there, if you do have patients that have a low sodium to potassium ratio, parasites, renal failure, urethral obstructions, pregnancy, any sort of cavitary effusion can all cause a low sodium potassium ratio as well. So the CBC is often normal, or there's a lack of a stress leukogram. Sometimes they may have a mild anemia, and their urinalysis is usually pretty unremarkable except for a dilute USG. So on your ECG, you can have some changes associated with your hyperkalemia. So obviously a wide range of electrolyte or ECG abnormalities can be seen. You may have microcardia on your radiographs just due to the patient being in hypovolemic shock. If you do an ultrasound, you may not be able to find the adrenal glands, or they're going to be small bilaterally. And then as far as kind of obtaining a diagnosis, a baseline cortisol is a good screening test. And they have SNAP tests for this now. If you do a baseline cortisol and it's greater than 2, Addison's disease is unlikely. If it's exactly 2 or less than 2, then they do recommend performing a confirmatory test, which would basically just be a full ACTH stim. You could also just do an endogenous ACTH level, but usually our stim is the mainstay. So the treatment is going to be fluid therapy, obviously. So we want to resuscitate them if they're in shock. So fluid boluses. I think a lot of, depending on which books you read, will recommend sodium chloride because there's no potassium in it, but really you can use any fluid. Typically LRS is just fine. It's okay that it has a little bit of potassium in it. You don't want to rapidly increase the sodium level too much. But the other mainstay is going to be replacing those hormones that are lost. So your glucocorticoids, typically we'll start replacing that with Dex-SP. So 0.1 mg per kg IV, and then kind of do a lower dose BID, switch them over to orals. And then you typically, again, will start at a higher dose and wean them down to where their maintenance is, but usually stay on the higher dose for about 3 to 5 days. And then if they have typical Addison's disease, so they do have the electrolyte derangements, supplementing the mineralocorticoids as well. So the mainstay is going to be DOCP, 2.2 mg per kg IM or sub-Q about every 25 days. So you're going to recheck the electrolytes typically in about 2 weeks after discharge, and then again right around that 25-day mark to kind of figure out when exactly those monthly injections are going to be due. Fludrocortisone, I don't have a lot of experience, but that's going to be your oral form that supplements both glucocorticoids and mineralocorticoids. But typically that's not going to be recommended during an initial crisis. We still want to do the Dex-SP, but it can certainly be a mainstay in a lot of, I think, countries overseas and things like that. They use that frequently. And then just your general supportive care. So things like antiemetics, gastroprotectants, things like that. Usually these cases will bounce back pretty quickly, so they can be quite rewarding because it's something treatable, and usually they have a pretty good survival rate if the diagnosis is obtained quickly. So moving on to case 6. This case is a 7-year-old male-neutered boxer. Not this case, I found this picture off the internet, but this is a dog that, let's say it's 2 days post-op. It had an RNA for septic peritonitis, perforated foreign body, and the dog has been persistently hypotensive despite being on norepinephrine CRI at 0.5 mics per kg per minute, which is typically the max rate that I will use for norepi, and norepinephrine would be my first choice for a vasopressor for septic patients. So if that's not working, then I'm a little concerned. And this dog may have CIRSE, or previously they've called this RAI, so relative adrenal insufficiency, but the CIRSE name I like a little better because it's a little more specific. So critical illness related corticosteroid insufficiency, or CIRSE. So basically this is just an inadequate production or utilization of cortisol in relation to an increased demand for cortisol. So this is going to happen during periods of severe stress or illness, so critically illness related, but it usually happens in septic shock. So they found that supplementing these patients with hydrocortisone in particular, not any other type of steroid, will improve the patient's responsiveness to the vasopressors, so like to norepi, and their blood pressure actually improves pretty quickly once you start them on this, and you can get them off the pressors sooner. So the diagnosis for this is a little tricky. There's not really a consensus. There were a lot of studies back maybe like 2006 area when they were doing a lot of research on this. But basically, if you have a patient whose blood pressure is not improving with fluids and all your pressors and improves with the hydrocortisone, then it likely had CIRSE. The surviving sepsis guidelines in humans don't really recommend an ACTH stimulation test for a diagnosis. They basically say, if you think it has it, then try the hydrocortisone. There was a veterinary study that looking at the change in cortisol levels. So patients that had a change in cortisol that was less than 3 mics per deciliter were more likely to be hypotensive and have a decreased survival rate. So that was kind of the only number that I had to go off in the studies that I found, and a lot doesn't seem to have changed. So the doses listed there, so 0.5 to 1 milligrams per kilogram IV once, and then Q6 hours if it's effective. So if it's not effective, you don't need to keep giving it, but if it does help, then it's usually every 6 hours. And typically these patients are not going to need lifelong therapy. So we typically will keep them on the hydrocortisone IV in hospital and then switch them over to like an oral prednisone and then kind of slowly taper that down by about 25% every day. So probably by the 2-week recheck when those staples come out, they may not need to be on the steroids. But kind of like when you're weaning Addison's patients to try and get their physiologic level, if they start doing worse, then you can always go back up on the dose. The prognosis for these guys is usually pretty poor. I mean, we're talking about a very sick septic animal whose blood pressure is low for several days that we can't improve. So I think that makes sense that their prognosis would overall be poor. If you can get them off pressors, their blood pressure is normal, and they go home, then typically, they will have a fair chance of having a normal HPA axis function. So again, they're probably not going to need lifelong steroids. And if you can get them through the crisis, they can often lead normal lives. So the next case is a 9-year-old female Spade Golden who comes in for lethargy, vomiting, and diarrhea. Pretty normal blood work, aside from a low potassium level. The PE exam was also normal. So this probably is something we see quite commonly. 2.9 potassium is fairly low. So that's kind of why I chose this case. But basically now we're going to delve into potassium disorders a little. So potassium is your primary intracellular cation. So if you think of low potassium levels, Think about decreased intake, so anorexia, or increased loss of the GI tract, things like vomiting, diarrhea. You can also have redistribution of the potassium, so insulin administration, like we talked about earlier with the DKAs, any sort of catecholamines, so epinephrine, things like that. Glucose administration will also shift the potassium around. Metabolic alkalosis occurs as well. And then they can also lose potassium through the kidneys. So renal disease, giving diuretics, mannitol, Cushing's disease, things like that. And drugs, penicillins, can also cause hypokalemia. So your physiologic effects of hypokalemia, you get basically your cell membrane potential, the resting potential increases with hypokalemia, so that makes it more negative, and it hyperpolarizes the cell. So you can see muscle weakness, so neck ventroflexion and plantigrade stance is pretty classic for cats with hypokalemia. You can also have smooth muscle weakness that leads to ileus, and eventually, if it's severe enough, you can get respiratory paralysis. You have impaired renal tubular function, you can have a glucose intolerance, and then you can get prolongation of your cardiac action potential. So we can often see depression of the ST segment, prolonged QT and a PR interval, an increased P wave amplitude, and a widened QRS. So the treatment is pretty standard. You want to supplement it in IV fluids. So something we do very commonly is add KCl to fluids, and KCl is typically our mainstay. Sometimes due to like back orders, we'll have to use a different formulation, but the potassium chloride is the standard one, and that is 2 milliequivalents per mil, so it's pretty easy to remember. The potassium phosphate, if you also have a low phosphorus, would be the one that I choose, has a little bit more potassium per mil. And then oral supplementation with things like Tumul K is also something that we do commonly, especially in cats. So typically we will just add a certain amount, like a milliequivalents per liter, to the IV fluid bag. And I have a chart that you guys have probably seen following this. If it's severe or if it's not responding to just the KCl in the fluids, or if I want to fine tune it a little bit, then sometimes we will start them on a CRI. You definitely want to dilute this and be very, very careful, because if you accidentally have a tech that boluses that, it would kill the patient. So, and when we are supplementing, we want to make sure we calculate our K max, which is going to be 0.5 milliequivalents per kg per hour. So we don't want to exceed that supplementation in our fluids. If you have a case where you're kind of not getting your potassium up despite increasing your supplementation, definitely check a magnesium. That can be causing refractory hypokalemia. Also check a calcium level, and then metabolic alkalosis can also make it harder to correct. And then monitor frequently. So depending on if I'm on a CRI, I will typically check lights every 4 to 6 hours. If it's just KCl in the fluids because it was mildly low, I think once a day is fine. So it depends on how low the potassium is and how much potassium I have in the fluids, but at least once a day, twice a day would probably be ideal, but not always possible. So this is the chart I was referring to, which, you know, I kind of have an idea in my head what the potassium is, but it's probably because I've just looked at this chart so much. So if it's severely low, so if it's less than 2 on your potassium level on the blood work, I would go ahead and add 80 milliequivalents per liter. You just want to make sure that that fluid rate doesn't go above 6 mils per kg per hour, or that would be over your K max. And again, if we've got that much potassium in the fluids, I always try and mark the fluid line so that no one boluses it accidentally. And then varying down, if it's just mildly low, just 20 milliequivalents per liter. But I think 30 is kind of what I would usually start with. But sometimes the potassium will increase and you may need to take that out. So just that's why monitoring is so important. So our next case is another common ER problem that we see. So it's a 3-year-old male neutered domestic short hair that presents for crying in the litter box. And on exam, the poor guy's got a large firm urinary bladder, so he's obstructed. He's quite acidemic on blood work, and his potassium is 9. He's got some crystals in his urine, but no bacteria. So the main concern here is going to be the hyperkalemia. And I would say this is by far the most common cause of hyperkalemia that I see, but some other causes are listed there. So if you're supplementing them, if they're taking in more, like TKAs, acute tumor lysis syndrome can also cause a hyperkalemia. So if you have a patient that just got chemo, definitely can cause hyperkalemia. Any sort of translocation from the intracellular to the extracellular space. So things like heat stroke, crushing injuries, reperfusion injury is also a pretty common cause of hyperkalemia. Anything that decreases the renal excretion of potassium is probably what we see most often. So anuric or oliguric renal failure, if you have that cat that's been in the hospital for 5 days and now their potassium's creeping up, I have concerns. UOs, uroabdomens, Addison's disease, GI disease. So lots and lots of things can cause this. There are some things that will artifactually increase the potassium. So akitas typically just have a large amount of potassium in their red blood cells. Animals that have a thrombocytosis can also have falsely elevated potassium levels, but typically they're not going to be high enough to where we would need to intervene. So one of the main things with hyperkalemia, and I know we mentioned some ECG changes that can occur with hypokalemia, but much more commonly does hyperkalemia result in cardiac arrest, basically. But here is just a chart of, as we progressively get a higher potassium level, what happens to the ECG. So at first, it may just be a peaked narrow T wave. As we get higher, sometimes we have a prolonged QRS and PR interval. If we're getting above 7, our P waves start getting smaller. And if we're above 8.5, we can see atrial standstill, so no P waves. And then greater than 10, we can see ventricular flutter, ventricular fibrillation, and asystole. So the treatment for hypokalemia, the main thing, the most important thing is going to be to increase the threshold potential for your action potential to be increased. So this is a nice chart from Di Bartola. So it kind of goes through, if we have a low potassium, that's going to lower the resting membrane potential. If we have a high potassium, that's going to increase the resting membrane potential. So potassium is going to affect the resting membrane potential. The calcium is going to affect the threshold, so where the action potential is going to initiate. So you can see the high potassium and the high calcium are beside each other. So because the high potassium raises that resting membrane potential, the area, there's a much smaller window. So these action potentials are going to be firing off much more quickly. So by giving calcium, we're going to raise that so that it has a longer way to go before the action potential is elicited. So that's just one of the main reasons that we give calcium gluconate to hyperkalemic animals. It's basically cardioprotective. So it's not going to actually do anything to lower the serum potassium, but it's going to protect the heart. So that is typically what I will tell interns, new ER doctors, technicians, reach for that first, because it's going to protect your heart. So the dose that we use is 0.5 to 1.5 mils per kg IV. It's typically given over about 10 to 15 minutes. Now that's specific for calcium gluconate. Sometimes that's hard to get and we would have to use calcium chloride, which is a different concentration. So I had to look up the dose. But if you have just your regular calcium gluconate 10%, you can do the mils per kg shortcut dose. You want to give it slowly and watch the ECG because giving calcium can also cause arrhythmias. So that's one thing to be sure and watch out for. So now that we've protected the heart, we want to work on shifting the potassium into the cells. So we do that from, basically there's several drugs that we can give to shift the potassium into the cells. Insulin certainly is probably the one on here that can have the most side effects, being they can become hypoglycemic. So you have to make sure to follow with dextrose and monitor. But the insulin will typically work within an hour, and the dose is anywhere from 0.1 to 0.25 units per kg of regular insulin IM. And again, we typically give that with dextrose. So 50% dextrose, the dose is 0.5 to 1 mil per kg IV, diluted 1-to-1 over 3 to 5 minutes. And then add that to fluids typically, unless they're like hyperglycemic after the bolus, but you want to recheck. Sodium bicarbonate you can give as well. That can also have some side effects. So it's usually like a last resort that I would give, but the dose is listed there. So typically we'll start with insulin and dextrose and calcium. And if it's still elevated, then that's when we'll do the beta agonist. So terbutaline or albuterol, whichever you have on hand. One or the other, you don't really need to do both, but the dose of terbutaline is listed there. And then the albuterol is something that you can give like if you're waiting on a catheter or something, because it is just intranasal. So sometimes that's easier. And then obviously other treatments for hyperkalemia. So IV fluids is going to help dilute that out. And if it's like a case of anuric renal failure, then you might be looking at hemodialysis, but that will quickly correct your hyperkalemia. So the same group that looked at the effect of glucose on kind of prognosis and causes of abnormal glucose levels in animals, that one was just in dogs that presented to an emergency room. They looked at what the potassium had an effect on in dogs and cats as well. So it was actually quite a few cases, and this is UC Davis. And basically, of all the animals that presented to the emergency room during this basically 1 year period, 27% of dogs and 40% of cats had an abnormal potassium concentration. So it's pretty common, whether it was high or low. They found that hypokalemia was most often associated with GI disease. So they're mostly looking at moderate to severe hypokalemia, and then hyperkalemia was usually associated with urinary tract disease, which if you think about just everyday cases that you see, that makes sense. Dogs that had hypokalemia and dogs and cats that had hyperkalemia did have a significantly greater mortality rate than those that had normal potassium levels. And again, so those were for animals that had moderate to severe changes. For dogs that just had mild hypokalemia or mild hyperkalemia, they also had a higher mortality rate, but that same wasn't true in dogs. So what I'm taking from this paper is that in dogs, any sort of electrolyte or potassium abnormality may be more significant, whereas in cats, it's usually just moderate to severe elevations that may make a difference. But I just thought that was interesting that they took that data, but it is quite common. So our next case, moving right along, is a 2-year-old female Spade terrier mix. And that presents, this animal presents for progression of abnormal behavior, so tremors, falling over for about the past 2 weeks, but this has been worsening in the past 24 hours. On exam, the patient is euhydrated, his pulses are weak, and he is basically in hypovolemic shock. So his blood pressure is low. His blood work, his sodium is 178 millimoles per liter, and his lactate is 6.2. And just for reference, he weighs about 10 kilograms. So obviously our main concern in this dog is hypernatremia. So sodium disorders is something that I think a lot of people are very afraid of. It's not nearly as common as our potassium disorders, and there are a lot of equations coming up, so I think that can just be intimidating. But if we try and keep it simple, I think that's how it makes the most sense. So basically, if we're thinking about the volume of our extracellular fluid, that's going to be determined by the total sodium content in the body. So your serum sodium level is going to indicate the amount of sodium in the extracellular fluid relative to the amount of water. So it's not going to be the total body water or the total body sodium. So it's just in the extracellular fluid. So if we think of hypernatremia, basically that patient has not enough water in their extracellular space. Hyponatremia, they have too much water. So again, we can get into kind of the regulation of plasma osmolality and ADH and things like that. But if we're trying to look at abnormalities we see on blood work, if we associate it with kind of too much or not enough water, I think it makes a little more sense. So for the hypernatremia, again, not enough water. We can see that from gaining sodium. So this would be kind of an iatrogenic thing. If we lived near the ocean, if a dog drank a bunch of seawater, Play-Doh toxicity, high salt content, beef jerky. If we give sodium bicarbonate or hypertonic saline, that can cause your sodium levels to increase. You could also have a pure water loss. So I've seen this in a few cases where maybe the animal was tied up or locked in a room while the owner was away for like 5-7 days, it didn't have any water. That's a pretty common reason for very high sodium levels. Diabetes insipidus is another common cause of hypernatremia, although in itself is not common, but I have seen that a few times. Respiratory loss, so panting, maybe they have a high fever, heat stroke, something like that. Or if they're just not drinking water, so they have a brain tumor, so they're not drinking, another common cause. And then also kind of loss through fluids like vomiting, diarrhea. If you have your osmotic diuresis, diabetes, mannitol can also cause hypernatremia. And then if you have chronic polyuric renal failure or a post-obstructive diuresis case, then your third space losses can also cause a hypernatremia. So as far as clinical signs, depending on how acutely they develop, if it's really acute, you may not see, or if it's really chronic, you may see kind of subtle neurologic changes, but in your acute cases, the neurologic signs are pretty commonly seen. So they can just range from depression, lethargy, to full-on comatose, sometimes seizures, ataxia, things like that. So as our plasma osmolality increases, remember we had that formula earlier, your sodium and chloride are going to move from your CSF into your cerebral tissues, and that's going to increase the osmolality of the neurons and draw water into the intracellular space. So within a few hours, the neurons are going to start accumulating these organic solutes or idiogenic osmoles, and they're going to do that to try and increase the intracellular osmolality and shift the lost water back into the intracellular space. So as these idiogenic osmoles form, this is the reason why we don't want to correct our sodium levels too quickly if it's something that's happened chronically, because we can shift these things around and that can make actually the neurologic signs worse. So the treatment for hypernatremia is basically going to parallel the speed with which the hypernatremia develops. So if it happened pretty quickly, like the dog ate the heavily containing salt Play-Doh this morning, we can do that a little more quickly than this dog that was not drinking water for 2 weeks or something like that. So it really depends on how long this has been going on. And then also kind of just looking at the patient's volume status. So if the patient is hypovolemic, then you want to resuscitate them with a fluid that has a similar sodium concentration as that of the patient's, which is sometimes hard to do if their sodium is greater than 180. Sometimes you have to get creative, make your own solutions, but you want to kind of be within 6 milliequivalents per liter. If you have hypernatremia that's due to like a hypotonic fluid loss, so like it's just vomiting, diarrhea, and usually these cases are going to be a little milder than if they have excess sodium gain or things like diabetes insipidus. But for those, you can correct with using like half-strength saline. Again, you don't want to exceed a certain amount, or you can cause neurologic signs, and that amount is 0.5 milliequivalents per kg per hour. So this is just a chart of the sodium content in different types of fluids that we use commonly. So LRS has 130 milliequivalents of sodium per liter. So that's our lowest kind of maintenance fluid that has the lowest sodium concentration. Norm R or Plasmolite have 140, so a little bit higher there. 0.9% saline has 513. Your hypertonic salines listed various concentrations there. Your half-strength saline is going to be 77 milliequivalents of sodium per liter, and then the D5W or 5% dextrose in water has 0. So in cases of severe hypernatremia, D5W is going to be our choice. If you didn't have that, using your half-strength saline can work as well. It's just not preferred in the cases of where the values are like greater than 180 or even greater than, I would say, like 170. So if you have the hypernatremia that's due to a free water loss, so you're losing free water, you want to calculate your free water deficit. So here's another formula. It's basically the body weight in kilograms times 0.6 times the patient's current sodium divided by normal sodium. And sometimes I'll even choose the normal sodium to be the high end of normal. So that will give you a value in liters, and then you can multiply that, or you can get that into milliliters and then divide that by how many hours you think this happened over. And that's going to be your rate to run your D5W at. So this free water deficit is going to be used to calculate the rate of D5W that you're going to use. If you're using half-strength saline, you don't need to do this formula because you're not going to be using the 0% sodium solution. So if you don't have D5W, you could also do this with regular water. If they're alert, you could measure it. You could place an NG tube and give this amount of just regular water through the NG tube. The problem is it's quite a high volume, so that may make them nauseous. And if they have ileus, that's just a lot more issues to deal with. For this, you don't want to correct faster than 1 milliequivalent per kg per hour if it's a mild to moderate increase in potassium that you're trying to correct, or if it's severe, we want to go even slower. So 0.5 to 1 if the sodium's like greater than 180. So once you've calculated your rate, and I didn't write this out, but for our case that I had at the beginning, 10 kilogram dog, basically if this happened over 4 days, the amount of free water to replace would be 6.6 liters. So if we correct that over 4 days, we're going to run that at about 70 mils an hour, which for a 10 kilogram dog seems like a lot, but they are going to be able to filter all that sodium as long as their kidneys are working well. So it's not going to contribute to fluid overload or anything like that. And the other thing to remember too is you want to also have the patient on its maintenance fluid. So I've often seen doctors who will start their D5W, they'll do this calculation, everything with that is correct, but they won't also put them on their regular fluids. So the patient should be on 2 different fluids, the D5W and the LRS or the Norm R or whatever you're giving to replace their dehydration or correct their losses or anything like that. So that's another important thing. And typically we want to monitor the sodium levels at least every 4 hours initially. I find, we can calculate everything and then it almost never goes exactly as planned. Sometimes it won't budge. Sometimes it will move too quickly. So basically every 4 hours, I'm checking what's my sodium now? What was it 4 hours ago? Am I correcting it too quickly? Not quickly enough is kind of what we'll often run into. And then I'll kind of turn up or down the rate based on that as well. So it's not like it has to stay at that rate the whole time. If you're going too quickly, turn it down a little. If it's not going at all, turn it up a little. So it's a lot of subjectivity as well, but monitoring is going to be very important. And then again, the maintenance fluids, just kind of leave those alone. So some other helpful formulas. If you want to estimate the correction of your change in serum sodium, so you can measure your infusate sodium. So let's say okay, if I give this animal LRS, how much is that going to change the sodium? Or let's say you don't have D5W. I'm going to give it normal, or I'm going to give it hypertonic saline. So you can go back to that chart that I had that has how many milliequivalents per liter the sodium is in each fluid. You can do that minus your patient's serum sodium level divided by their total body water. And that will kind of estimate what you would be getting. So that may take a little more math or work, or you're kind of just plugging in numbers, but that's also a double check system. And then you can also measure kind of the rate of infusion. So how many mils per hour of fluids you're going to give. Again, this is going to be if you're not using D5W. So your total body water times whatever you want the sodium to be. So whether that's high normal, normal, minus whatever the patient's sodium is at the time, times 1,000, and then divided by whatever sodium content is in your fluid. So if it's LRS, it would be divided by 130 times the number of hours you're going to give it over. So that's another formula that can be used commonly. So our next case is a 2-year-old male neutered doodle who presents for abnormal behavior after drinking an unknown amount of lake water about an hour prior to presentation. So this doodle is 20 kilograms. He's about 5% dehydrated. He doesn't have any signs of shock on his exam, and his blood work is normal except for a sodium of 120 millimoles per liter. So hyponatremia, I would say, is not as commonly a concern as hypernatremia. I'd say it probably comes up more frequently, but it's usually not severe enough to where we have to bust out our formulas as often as hypernatremia is, but it can certainly result in similar neurologic changes, and we run into the same problem if we don't want to correct it too quickly, things like that. So in general, broad categories of reasons your sodium level may be low is you're losing sodium. So diuretics, Addison's disease, you're losing it through the GI tract, severe burn cases, uroabdomens, things like that. Or you have too much free water. So heart failure, nephrotic syndrome, liver disease, psychogenic polydipsia, syndrome of inappropriate ADH hormone is another rare endocrine disease, hyperglycemia. So again, that kind of pseudo hyponatremia we talked about earlier, mannitol as well. So again, kind of that correction factor for every 100 milligrams per deciliter increase in blood sugar, there's a 1.6 milliequivalent per liter drop in sodium. So our clinical signs are usually not present unless hyponatremia is severe, so less than 120. So these signs can be things like weakness, hypotension, shock. They may have neurologic signs such as obtundation, head pressing, coma, or seizures. They can have GI signs like vomiting, anorexia, abdominal pain, or ileus. So neurologic effects are kind of similar. So hyponatremia causes water to move into the relatively hyperosmolar cell. So you get cell swelling. And then once you have these swollen neurons, they're going to expel sodium, also potassium, and these etiogenic osmoles as well to try and decrease the osmolality within the cells. And then that's going to encourage water loss through the extracellular fluid. So the treatment, if they're asymptomatic and they're kind of fluid overloaded, restricting their water. I would say that that's almost never quite how they present. Oftentimes they'll be asymptomatic and either euhydrated or a little dehydrated. That would probably be the most common way that they present. And in that case, you want to use IV fluids with a little bit higher sodium than the patient's sodium. So again, kind of that chart I had with the different levels. So LRS is going to be your lowest maintenance fluid at 130 milliequivalents per liter of sodium. If the patient is symptomatic, so if they're having neurologic signs, then we have to, again, calculate. So this time we're going to calculate the sodium deficit. So it's the total body water, which is just the 0.6 times the body weight in kilograms, times whatever sodium you want the patient to be at minus where they are. So again, we want to correct this slowly. So if this has been going on for days or weeks, we want to correct it no quicker than about 0.5 milliequivalents per liter per hour, or 10 to 12 milliequivalents per liter per day. If it's acute, like in our case where the dog drank the water quickly at the lake, we can correct that a little quicker. So 1 to 2 milliequivalents per liter per hour. So that brings us on to our next case. So a Rottweiler, 10-year-old male neutered, presents for PUPD and weight loss. On exam, he is euhydrated and thin. His blood work, the main thing that you note is a calcium level of 15.2. His phosphorus is low normal and his liver enzymes are mildly elevated. His urinalysis, his urine specific gravity is 1012. He does have white blood cells, coccyne rods in his urine. So when we're thinking about calcium disorders, again, this could be a whole other topic, but calcium is very important for cardiovascular and neuromuscular function. It's necessary for muscle contraction, coagulation. The ionized form is the biologically active form. And if we're talking about maintaining our calcium levels, we have our PTH that increases calcium in response to a low calcium, and your vitamin D or your calcitriol is going to increase calcium in the intestines, the kidneys, and the bone, and your calcitonin is going to decrease your calcium by inhibiting bone resorption. So for hyperkalemia, this is the mnemonic that I was taught as far as differentials go, hogs and yard. So Addison's, renal failure, hypervitaminosis D, we will see with a certain type of like cholecalciferol rodenticide toxicity. Young animals typically will have higher calcium levels, neoplasia, so anal sac adenocarcinoma, lymphoma, multiple myeloma. In cats, they can get an idiopathic hypercalcemia, granulomatous, so fungal diseases, osteolysis, and then hyperparathyroid as well. So clinical signs, PUPD, anorexia, lethargy, it's pretty much a clinical sign of any of these diseases. Constipation, vomiting can also occur. They can have neurologic signs, bradycardia, and they can get mineralization of the tissues if the calcium phosphorus product is greater than 70. So the treatment, just looking at treating the specific high calcium levels, not necessarily the cause. You want to use 0.9% sodium chloride diuresis. This is probably the one case where I would actually want to choose NaCl versus LRS or Norm R. Again, it's not wrong to choose it for other cases, but this would be one where I would actually stick to that. Lasix can also be used as well. So that's going to enhance your urinary calcium loss by inhibiting calcium reabsorption in the loop of Henle. Steroids, I would wait until you get a diagnosis, especially if you're worried about neoplasia. If you need to aspirate a liver or a spleen or something, you want to aspirate that, get your answer first, and then start your steroids. So either Dex-SP or prednisone is fine. And that's going to decrease bone reabsorption and also decrease your intestinal calcium reabsorption and increase your renal excretion. So that one works kind of on all three levels. Calcitonin and sodium bicarbonate you could also use. I don't give those commonly. Your bisphosphonates, so pamidronate or zolidronate is kind of the newer one. A lot of oncology staff will know how to use that and keep on hand, and then obviously dialysis as well. Back to our particular case, we did a parathyroid panel on this dog, and its PTH was 17.5, so it was elevated. Its ionized calcium was 2.07, and its PTH-RP was 0. So in this case, we had radiologists come and ultrasound the parathyroid gland, and they did find a nodule. So as far as treatment goes for this dog, we could take him to surgery to remove that affected parathyroid gland, or refer for ultrasound guided heat ablation or ethanol ablation. So moving right along, our next case is a 2-year-old female intact Frenchie who presents for tremors and panting. And you find out from the owners that she just whelped 3 days ago. And she presents having generalized tremors. She's dyspneic, she has hyperemic mucous membranes, she's hyperthermic, and she's tachycardic. And on blood work, her ionized calcium is 0.5. So in this case, we're dealing with hypocalcemia. And this dog has eclampsia from her puppies that she just had. Other common causes, low albumin, renal failure, pancreatitis, any sort of soft tissue trauma, hypoparathyroidism. Ethylene glycol intoxication can cause a low calcium level, intestinal malabsorption, PLE, starvation, acute tumor lysis syndrome, blood transfusions, things like that can all cause a hypocalcemia. So if severe enough, the signs can include muscle twitching, stiffness, ataxia, or seizures. We can see hyperthermia, hypotension, tachyarrhythmias, and prolonged QT intervals. In cats, we can often see a prolapse of their third eyelid. In some cases, we'll have facial rubbing and cataracts as well. So the treatment, certainly in the acute stage, we want to give them calcium supplementation with calcium gluconate. The 10% again is our most common, and we want to do the dose same as when we're treating for hyperkalemia, 0.5 to 1.5 mils per kg IV. We're going to do that slowly. We're going to watch the ECG because again, we can see electrolyte changes, and then typically recheck about an hour post bolus. Depending on the severity or how long it's been going on or the underlying cause, sometimes you may supplement with a CRI of calcium gluconate. I'll say that's something I have rarely done, if ever. And then your calcitriol is going to be more for like your hypoparathyroid patients. And then long-term, you can supplement with Tums at 100 to 150 mg per kg per day. So often for these postpartum animals that come in with a low calcium, I'll send them home with a dose of Tums to give. Obviously, we want to treat the underlying cause. So if they have whelped, we want to remove the puppies. So no more nursing for mom, and just kind of treat whatever underlying issue the animal has. Hypocalcemia itself has been studied a lot as a prognostic indicator, like regardless of the cause. There are several papers looking at different diseases and whether ionized hypocalcemia was associated with survival. So there's one paper in dogs that presented to an ER with trauma, and they found that those that were hypocalcemic were more severely injured and had a lower likelihood of survival. And then with septic dogs, another paper found those that died did typically have a lower ionized calcium than those that were euthanized or survived. And then in a study of cats with acute pancreatitis, a low ionized calcium was associated with a poorer outcome. So it's definitely something, if you have a sick patient, maybe they're not, their hypocalcemia is not what you're primarily treating, but if you note that, that can kind of be helpful just to tell owners like, hey, we do have a prognostic indicator that your pet could be more sick than what we thought. So sometimes that's helpful to have. Moving along, our next case is a 13-year-old female spayed domestic short hair. She presents after being missing for 1 month. She has a history of being hyperthyroidism, and she was receiving her methimazole up until the date that she went missing. So when this cat comes in, she's severely dehydrated, she's thin, she's tachycardic, she's hyperthermic, she's mildly anemic, she has a neutrophilia, a mildly increased ALT, mild hyperglycemia, and a mild hypokalemia. And her total T4 is 17. So this could be an example of a case that might present in a thyroid storm. So thyroid storm is a multi-system disorder that results from organ exposure to excessive amounts of circulating thyroid hormones. So we basically get hyperactivation of the sympathetic nervous system, and you have an increased cellular response to the thyroid hormones. So there's a couple things that could precipitate a thyroid storm, getting radioactive iodine, having any sort of thyroidal or parathyroidal surgery. So in dogs, there is a case report of a dog with a thyroid storm that had a thyroid carcinoma and then was taken to surgery. If you have abrupt withdrawal of any sort of anti-thyroid medications, that could in theory cause this. Any sort of stress or non-thyroidal illness could also cause this. And it's even reported like the vigorous palpation of the thyroid gland can cause it, although I don't know that I've ever actually seen that or if there's any reports of that. So clinical signs, typically we'll have a fever, but not always. CNS signs can be seen, so they could be agitated. They can have behavior changes, they can have seizures. GI signs, pretty common, as well as cardiovascular signs. So anything ranging from heart block to AFib. You can see congestive heart failure, retinopathies, thromboembolic disease, cervical ventriflexion, and severe weakness. So the diagnosis is pretty much based on your signs plus evidence of a precipitating event, and then obviously an increased total T4 or free T4. And in most cases, the magnitude of change is more important than the actual value. So if you went from like a 4 all the way to like a 20, that may be more significant than going from a 17 to a 20 on your T4 level. Typically on blood work, the findings are going to be pretty non-specific. So an anemia, stress leukogram, increased liver enzymes, some electrolyte abnormalities that we've already talked about. So nothing really specific on just your regular CBC chem. So the treatment, you want to reduce the production and secretion of new thyroid hormones. So methimazole, you could use potassium iodine, steroids. You want to also treat basically the peripheral effects of the thyroid hormone. So the beta blockers are going to be another mainstay. So atenolol is great because it's once a day and it's selective for your beta 1. You can also use propranolol or esmolol that are IV. Symptomatic support, so IV fluids, fans, treating any other abnormalities like heart failure, arrhythmias, monitor the blood pressure. You may need your antihypertensives as well, and then correct any underlying precipitating factor. So as far as the thyroid storm prognosis, I didn't really find a lot, so I would say basically the studies are lacking. Okay, we're getting down to, I think, the last few here. So the next case is an 11-year-old male neutered Labrador who presents for lethargy and dull mentation. On exam, he's stuporous, he's got edematous jowls, he's overweight, he's hypothermic, and he has a thin hair coat. His blood work shows that he's mildly anemic, he has an elevated ALP and a lactate, and his total T4 is 0.2. So this dog, we'll say, has basically a mixed edema coma. So that's going to be a rare complication of hypothyroidism. So you can get mixed edema, which is basically an accumulation of hyaluronic acid and mucopolysaccharide in the dermis, and that's going to cause water retention and non-pitting edema. You can get an altered mental function due to decreased blood flow, and oxygen delivery to the brain. You have altered thermal regulation, and you can get hypoventilation as well, secondary to decreased responsiveness to hypoxia and hypercapnia. So the risk factors, some breeds have been overrepresented, like Rotties, Dobermans. The presence of some other disorder, like an infection somewhere else, is the most common kind of risk factor for developing this. Previous glucocorticoid or NSAID use has also been associated with this. Prior surgery, and then dogs that have untreated hypothyroidism are more at risk. The clinical signs are going to be things like hypothermia, as we talked about, altered thermal regulation. They're typically not cold, they're not shivering. They could also be hyperthermic, and then we can get the mixed edema of the face and the jowls. They can be tachypnic, dehydrated. Typically, there is some level of altered consciousness, so stuporous or dull. A lot of times they just don't want to move. They'll just be laying in the kennel. It's very hard to get them up. They almost appear sedated. They could be bradycardic or tachycardic. They can be hypotensive. And then the typical signs of a hypothyroid dog, such as your alopecia, thin hair coat, things like that. So your diagnosis, a low T4 plus or minus a high TSH is seen. Blood work changes are, again, nonspecific. So maybe an anemia, lipemia, increased ALP, high lactate, hypercarbia, things like that. Treatment, IV levothyroxine is preferred at 5 mics per kg BID. Warming, IV fluids. In severe cases, they may actually need to be ventilated if they're that hypercapnia. Treat any sort of underlying disease, so treat the infection, things like that. If they do have heart disease, you want to use a lower dose of your levothyroxine, and you want to discontinue any medications that may make things worse. So if they are on steroids or an NSAID, definitely stop or at least wean the steroids. And as far as prognosis goes, in one small study, they did find that 87% were discharged. So probably a better prognosis than with like a thyroid storm, obviously different diseases, but typically with treatment, the animal's mentation will start to improve within about 24 to 30 hours once you start supplementing them. Okay. The next case is a 12-year-old female Spade Terrier who presents for anxiety, trembling, and inappetence for 24 hours. On exam, the dog is pretty bright and alert, euhydrated. She's a little tense on abdominal palpation. Her blood work is normal. Her urinalysis showed a USG of 1036 with a 2+ proteinuria, and her blood pressure was elevated at 230. You do your fast scan in the emergency room, and you see what looks to be a mid-abdominal mass. Let's say you do a CT, and this is what you find. So you have a large mass that's encompassing the kidney and extending cranially, and it's quite invasive, and there's actually a filling defect in the caudal vena cava. So this dog has a pheochromocytoma, so not super common, but certainly an endocrine disease that you may want to recognize quickly. Basically, it's a tumor of the chromaffin cells of the adrenal medulla. So these are the cells that synthesize, store, and secrete catecholamines. Clinical signs can be pretty vague. Sometimes they'll come in for weakness, syncope, lethargy or vomiting. They can be tachypnic. They can have a distended abdomen. They can be painful on abdominal palpation. They'll often present hypertensive and either tachycardic or bradycardic, depending, but there may not always be. And sometimes these signs come and go, typically because of the cyclic nature of the catecholamine release. So diagnosis, these are often found incidentally on an ultrasound, but they can, if they come in during an episode where those catecholamines are being released, they may be symptomatic for this. The CT is useful for determining how invasive these tumors are, and depending on the study, anywhere from 15 to 38% of PHEOs are going to invade the caudal vena cava. You could do scintigraphy. You could measure the urine catecholamine concentrations. You could also do an FNA or a biopsy, but typically, based on the signs, the hypertension, and the location, if it is invading the caudal vena cava, we're just going to assume it's a FEO and be prepared to kind of manage it as such. So treatment, we can certainly surgically remove these, but it's a very risky surgery, and post-operatively, they tend to not do very well. Cardiovascular collapse, if it does occur, it's usually not sensitive to the catecholamines because these patients are just used to catecholamines being released all the time, so they're not going to respond to them. So often you'll need to use things like vasopressin if you want to get their blood pressure up post-op, which is quite expensive. Medical therapy can be attempted, especially if you just find it incidentally. So phenoxybenzamine is going to be the mainstay, and that's an alpha adrenergic blocker. And that can blunt the effects of hypertension, but it's going to bind to your alpha 1 and 2s and block the response to the circulating catecholamines. You also want to treat any sort of arrhythmias. You want to avoid using beta blockers when you're on the phenoxybenzamine, and you can also treat them just with fluids and things like that. But basically, phenoxybenzamine should be started if you're worried about it, and then ideally they would be on the phenoxybenzamine for a little while before taking them to surgery. So I think this is the last case that I have. So this is a 12-year-old female spayed domestic short hair. She presents for acute blindness and PUPD for months. On exam, she's mildly tachycardic. She has a 2 out of 6 heart murmur. She has an absent menace bilaterally. She has mydriasis, OU, and absent PLRs, OU. Her blood pressure is 230 when you take it, and her blood gas shows a potassium of 1.9, a sodium of 155, a chloride of 118. pH is mildly elevated, as is the bicarb, and the base excess, and it's mildly hyperglycemic. So this case is going to be a primary hyperaldosterone cat. So kind of the main things would be the low sodium or the low potassium level and the high blood pressure. Those are two things that are concerning for primary hyperaldosteronism, but this occurs when you get excess aldosterone being secreted for the zona glomerulosa of the adrenal cortex. So you get an increased sodium retention, which causes expansion of the extracellular fluid volume and an overall increase in total body sodium content. And you have potassium depletion occurring due to an increased urinary loss. And this kind of occurs generally by either an idiopathic kind of hyperplasia of that zona glomerulosa, or either a unilateral or a bilateral adenoma or an adenocarcinoma of the adrenal gland in cats. So clinical signs, like I mentioned, hypertension would be something that we would find when we measured the blood pressure. So signs of hypertension retinopathy. They can also be very weak. They can have that cervical ventroflexion, dysphagia, all that can be related to the low potassium. They can have heart murmurs. They can have PUPD, weight loss, kind of general non-specific signs as well. On blood work, severe hypokalemia is going to be the main kind of key indicator. They can also have a mild hypernatremia, a metabolic alkalosis. They can have a hyperglycemia. It's usually pretty mild, an increased CK if that's measured, and they may or may not be azotemic. So the diagnosis, there's several different things that you can do. Kind of the most common screening level would be like to run an aldosterone level. You could do an aldosterone to renin ratio. You can do all these confirmatory tests. You can do a CT scan to look to see if there's any tumors on the adrenal glands. If you're trying to decide, unilateral, bilateral, any sort of metastatic things, you can do adrenal vein sampling. You can also measure your urinary concentrations of aldosterone and creatinine. And sometimes you can find these things on abdominal ultrasound too. So that's a nice screening tool to be used as well. So similar to your insulin glucose ratio, you want to draw your aldosterone levels, or if you're doing the aldosterone renin ratio, when the potassium is low. So before you've corrected it. So kind of right off the bat. And then treatment, I can't say that I've seen a surgical case of this. So mostly it's medical management. And again, this is not very common. I'm not sure how frequently our internists see this, but it's pretty rare. But just something to keep in mind if you have a cat with hypokalemia that's hypertensive and you can't find another cause for the hypokalemia. But the medical management, the spironolactone is going to be the mainstay. So that's going to be your aldosterone antagonist, which makes sense if they're making too much of it. So the initial dose is going to be 2 mg per kg twice a day. You can titrate up to 4 mg per kg. Supplementing the potassium is going to be important. And then your antihypertensives as well. So in severe cases where they have an acute retinopathy and you're trying to get that blood pressure down to potentially reverse changes, you can use sodium nitroprusside, which we do have. We don't use it very commonly. There can be lots of side effects. The doses are listed there. You should be able to monitor the blood pressure at least hourly or every 30 minutes if you're going to use that. But typically, you know, if it's just mild and the cat is not that clinical, amlodipine is fine to start, as well as the aldosterone antagonist with the spironolactone, and then, you know, like oral Tumble K, things like that. And then you can do surgery if it's unilateral. So for this case, we did all those, like we did a full workup, our full blood work, urinalysis, and chest rads were all normal. And then our ultrasound did show a right-sided nodule kind of next to the liver in the caudal vena cava. And we were able to measure the aldosterone. It was elevated and the renin was low. So we treated the cat's hypertension with sodium nitroprusside and amlodipine. We started the spironolactone and Tumble K, and then the owners were going to consider surgery. So that is all that I had for you guys. So I can take any questions now if anyone has any. And then a lot of papers there. But to